Well, as you know, South Africa has been ramping up testing for COVID-19 since the start of the outbreak. Now, around 190,000 tests have been conducted in South Africa so far. But what are the criteria for testing? Very pleased to tell you, joined by the epidemiologist, Professor Salim Abdool Karim. He joins us again today to answer some burning questions. Professor, so good to see you once again on the Pulse. Thanks indeed for your time. I can't imagine how you fit us in every day. I know there's been some discussion around this, when you get tested, when you don't. At the moment in South Africa, at what point is someone in the health department or a doctor or someone who screened you going to say, you're going for a test?
As it stands right now, we have clear criteria by which we decide who to test. And it's essentially based on symptoms. So we have a clinical case definition, which is somebody who presents with an acute respiratory disease and they have one of four symptoms. And that's cough, fever, sore throat, or shortness of breath. If you have any one of those, then we regard you as potentially a suspected case of COVID-19 and you need to be tested. We have a separate definition for surveillance purposes, and in the case of surveillance, we can vary our criteria depending on what we're trying to do. Right now, we are in our community outreach programs. We are administering our questionnaires, and we're trying to get a symptom checklist from each and every person. And if there's a high index of suspicion that they may have COVID-19, then we proceed to referring them for a test in order to establish whether they have the virus or not.
Okay, so if someone in my immediate circle, a member of my family, someone I work with on a daily basis, tests positive for COVID-19, that doesn't mean I get a test immediately?
No, it does not mean that at all. The way in which we do that is as soon as we identify somebody who has an index of suspicion, we would recommend that they take a test, and as soon as they've taken the test, part of that is to institute a quarantine so that the individuals, until we know whether this person is positive or not, that they are not spreading the virus out to others. As soon as the result comes back, and that takes about 2 to 3 days, when the result comes back, and if that person is negative, then we de-quarantine everyone. If the person is positive, then we switch to isolating that individual from everyone else, and we quarantine the contacts that have been exposed, and we offer them testing in order to establish whether they have acquired the virus or not. So it's a very standard procedure. We've been doing it now since the beginning of this epidemic, and it works quite well usually. There are some individuals who don't follow their isolation procedures and need to be sort of focused on, but mostly we have found that people do quite well with self-isolation and self-quarantine.
Okay, obviously the test is not free. It costs someone money. Government is dealing with limited resources. The private sector is also dealing with limited resources, I suppose. There will be an argument to say we should just test as many people as we can. That, I presume, is not actually the sensible approach at this stage.
Well, it's not sensible for many reasons. One is, if you have no symptoms, then there's about 55 million people like that in this country. Who do we test, or who do we prioritize? So it doesn't make sense to do that at this stage. Also, it's difficult to get hold of the tests. For us to be able to purchase the kinds of quantities we need for South Africa, if we have to start offering these tests to people who are completely asymptomatic, then we will start finding that the laboratories are overworked and that patients who are genuinely positive, it takes us too long to get their results to them, and they may be starting to spread the virus as a result. So we have to keep a very fine balance. We do want to expand our testing, and we have, and you can see that in the numbers. We're actually doing quite well in terms of ramping up our testing. But we have to reach a point where at the moment, we are doing 40 tests to get one positive. So we don't want to get much worse than that. If we are doing 50 tests, 60 tests, 70 tests just for one positive, then we have to consider whether we actually are not optimally utilizing this resource and that we may need to be more focused in who we test. So all in all, if you are totally asymptomatic, if you want to, you can go to the private sector and get a test, but it's not the wisest use of your resources. Secondly, a PCR test in somebody who is asymptomatic is not the best test to use, because the PCR test, the polymerase chain reaction, the current test we use to look for the virus, the presence of the RNA of the virus in the throat and the nose, that test is only positive for about 2 to 3 weeks after the person is symptomatic. So in somebody who is asymptomatic, we don't know when you got infected, and so the test, even if it comes back negative, is not helpful.
Okay, I mean, I suppose in a way epidemiology is about symptoms and maths, and what you're suggesting here is also about the money of resources. The Western Cape has suggested that when it comes to the border between the Western Cape and the Eastern Cape, they would set up a system where you would be able to get a test within an hour, and they're obviously talking about the antibody test. We've been talking about the PCR test up until now, you and I. The antibody test, which we know is not as reliable as the PCR test. Would you support that kind of plan? That would mean that people would only be able to move between those provinces, the Eastern Cape and the Western Cape, if they took the antibody test. Is there any merit in that?
There have been some suggestions, and in some countries they even say that if somebody has an antibody, that they can then freely go back to work and not be concerned. I have to say that is built on very flimsy evidence. Right now, the evidence suggests that we do not yet fully understand and appreciate and know whether somebody who has antibodies against the virus, whether they are protected against it. And if we do not know whether they are protected against the virus, then it's pointless using it as a criterion. We do not think that this is a good idea, to use antibody tests to determine whether somebody is immune or not immune, because we yet don't fully understand what the antibody tests mean. Antibody tests have a different role, and that is, if you are looking at an outbreak situation, let's say the virus has been spreading for several weeks, and you need to get some idea of who was exposed and who was not exposed, and a PCR test is only positive for a short while. So in those instances, an antibody test is helpful because it tells us who may have been exposed to the virus. Similarly, if we're trying to get some idea of surveillance, we can use antibody tests. But to use it to make individual decisions about who may be immune and not immune, that is a very questionable practice.
Professor Salim Abdool Karim, he's with us here on The Pulse. We'll be back in a moment to answer some of the questions you've posed. Do stay with us here on The Pulse. Some of your questions, well, let's have a look at those questions. The first comes from Ephraim Mokhanedi, and Ephraim puts it like this, Professor. He says, "Hi, Prof, will the reopening of schools by the Department of Education not exacerbate the problem, and is that against your expert advice?" And he is from Mokopane in Limpopo. Professor, what's your response to that? I mean, the reopening of schools, it's a hot topic this afternoon. Could that make the problem that we're facing worse?
So I think there's a fundamental misunderstanding that this epidemic is going to go away sometime soon and that things can get back to normal at that point. I need to explain that we are now going to go into a new normal, and we are going to have to find a way in which we will live with this virus. Even when we have an epidemic curve and we get a peak of infection, even after that, we will remain at risk because we do not have any natural immunity against this virus. So we have to figure out how we are going to live, survive, and manage in our everyday lives in the midst of the threat of this virus. It's not going away anytime soon. So if we're to do that, we're going to have to find a way in which we open our schools in a systematic way, and a lot of deep thought and careful planning has gone into that. So it is something that we have to do. We cannot sit back and say, okay, we're going to wait for another 2 months and then maybe we'll open schools. Or we'll wait till the end of the year and maybe we'll open schools next year. This virus is still going to be here next year. So we have to figure out how to do that and how to do it now.
All right, Ephraim, thank you for your question. We've got another question coming through as well. Let's just have a look at that second question. And it comes from Nita Beerkus Market. Nita, you say, what is the risk for children with underlying medical conditions? And Professor, what's interesting about this is that we've seen that children generally aren't very vulnerable to the disease, but I know in other countries there are some cases where children have, I understand, passed away because of it. What is the risk for children with underlying medical conditions?
So the data we have came from studies that were done in China, and there's a new study also now available from the US as well, that gives us some idea of the profile of the illness that children get. And you're right, most of the children get a very mild condition. They don't even know that they've had it. In a few, they get a bit of diarrhea. In some, they get a bit of a cough, a runny nose. So it's a combination of these kinds of symptoms. Generally, they're mild. Now, it has to be said that there is a case fatality rate in children, but it's very low and much lower than what we see in adults. So generally, it is correct to say that this is a very mild disease in childhood. The question comes is, are there children who are particularly at risk? And that is not clear at this time. There is some emerging evidence, but it would be hard for me to give a definitive answer to the question that has been raised. I would say that as the evidence becomes available, we will make that clearer about which children are particularly at risk. At this point, that is not clear, and so we're treating all children equally at this time.
Professor Salim Abdool Karim, really do appreciate your time with us on The Pulse. Thank you so much, and thank you for agreeing to take your questions today here on The Pulse. You can, of course, send them through to us on Facebook and on Twitter.